In this video, we will be covering aneurysms. The aorta is the largest artery. It supplies oxygen, nutrients, and blood to all vital organs. One of the most common problems affecting the aorta is an aneurysm, which is a permanent localized outpouching or dilation of the vessel wall. Aneurysms occur more often in men and in whites. The incidence increases with age. Aneurysms may occur in more than one location. The aorta is the most common site for aneurysms. However, they may form in any vessel. Peripheral vessel aneurysms may involve the renal artery, subclavian artery, popliteal artery, or any major artery. The aneurysm produces a pulsating mass and may cause pain or pressure on surrounding structures. The large veins in the chest are compressed by the aneurysms, whereas the superficial veins of the chest, neck, or arms become dilated. Areas on the chest wall become edematous, and cyanosis are often evident. Pressure against the cervical sympathetic chain can result in unequal pupils. Now we will see the classification of aneurysms. Aneurysms are classified as true or false aneurysms. A true aneurysm is one in which the wall of the artery forms the aneurysm with at least one vessel layer still intact. A false aneurysm or pseudoaneurysm is not an aneurysm. It is a disruption of all arterial wall layers with bleeding that is contained by surrounding anatomical structures. False aneurysms may result from trauma, infection, peripheral artery bypass, graft surgery, that is, at the site of the graft to artery anastomosis, or arterial leakage after removal of a cannula. For example, femoral artery catheter, intra-aortic balloon pump. Morphologically, aneurysms may be classified by its shape or form. They are saccular, fusiform, dissecting. Saccular aneurysms are the distension of a vessel projecting from one side. A saccular aneurysm is pouch-like with a narrow neck connecting the bulge to one side of the arterial wall. Fusiform aneurysms are the distension of the whole artery, that is, the entire circumference is involved. A fusiform aneurysm is circumferential and relatively uniform in shape. In dissecting aneurysm, the hemorrhagic or intramural hematoma separating the medial layer of the aortic wall. Very small aneurysms due to localized infection are called mycotic aneurysms. Now we will see the etiology of aneurysm. A variety of disorders are associated with aortic aneurysms. The main causes are classified as degenerative. For example, atherosclerosis. It can be caused by congenital, infectious, mechanical, for example, penetrating or blunt trauma, and it can be caused by inflammation, for example, aortitis. It can be caused by hereditary immunologic conditions. False aneurysms are associated with the trauma to the arterial wall, as in blunt trauma or trauma associated with arterial punctures for angiography or cardiac catheterization. The ascending aorta and aortic arc are the sites of greatest hemodynamic stress and also are the most common sites of arterial dissection. Aortic aneurysms may involve the aortic arc and the thoracic or abdominal aorta. 3/4 of aortic aneurysms occur in the abdominal aorta. Most abdominal aortic aneurysms occur below the renal arteries. What are the risk factors? Because of vascular changes that occur as a natural process of aging, all patients over age 65 are assessed for the potential for aneurysms. Risk factors include male gender, hypertension, arteriosclerosis, local infection, pyogenic or fungal infection, congenital weakness of vessels, syphilis, trauma, coronary artery disease, family history, high cholesterol, lower respiratory peripheral artery disease, carotid artery disease, previous stroke, obesity, tobacco use. Tobacco use is the most important modifiable risk factor. The larger the aneurysm, the greater is the risk for rupture. Aneurysms are potentially serious if they are located in large vessels that rupture. This can lead to hemorrhage and death. Other causes of aneurysm formation are classified etiologically are genetic link or congenital. Both aortic aneurysm and aortic dissection have a strong genetic component. The familial tendency is related to several congenital anomalies. Examples include bicuspid aortic valve, coarctation of the aorta, Turner syndrome, autosomal dominant polycystic kidney disease, specific collagen defects. Example, Ehlers-Danlos syndrome. and premature breakdown of vascular elastic tissue, for example, Marfan syndrome, and other diseases such as focal medial agenesis, tuberous sclerosis, and Menkes syndrome. Next is mechanical or hemodynamic. These include post-stenotic and arteriovenous fistula and amputation-related problems. Next is traumatic or pseudoaneurysms. These include penetrating arterial injuries and blunt arterial injuries. Next is inflammatory, associated with arthritis like Takayasu disease, giant cell arthritis, systemic lupus erythematosus, Behçet syndrome, Kawasaki disease, periarterial inflammation, for example, pancreatitis. These comes under non-infectious inflammatory problem. Bacterial, fungal, spirochetal infections comes under infectious inflammatory problem. Next is pregnancy-related degenerative, which include non-specific inflammatory variant. Next is anastomotic or post-arteriotomy and graft aneurysms. This is associated with infection, arterial wall failure, suture failure, graft failure. Now we will see the pathophysiology of aneurysm. All aneurysms involve a damaged medial layer of the vessel. This may be caused by congenital weakness, trauma, or disease. After an aneurysm develops, it tends to enlarge. More than half of patients with aneurysms have hypertension. An aneurysm is a distension formed at a weak point in the wall of the artery because of a weakening or destruction of the arterial wall. They are lined with intraluminal debris such as plaque and thrombi. Because of the high pressure in the artery system, aneurysms can enlarge, producing complications by compressing surrounding structures. If they are left untreated, they may rupture, causing a fatal hemorrhage. A dissection occurs when the layers of the artery become separated. Blood flows between the layers, causing further disruption of the arterial wall. Additionally, the intraluminal thrombus may totally occlude the artery, leading to acute ischemia to all arteries distal to the area of thrombosis. Or they may embolize, clot, and or plaque to the arteries distal to the aneurysm. How to diagnose the aneurysms? Abdominal or chest X-ray may show calcification that outlines the aneurysm. Chest X-rays may reveal abnormal widening of the thoracic aorta. An abdominal X-ray may show calcification within the aortic wall. An ECG may rule out MI, since thoracic aneurysms or dissection symptoms can mimic angina. Echocardiography assesses the function of the aortic wall. A CT scan or MRI scan can diagnose and assess the location and severity of aneurysms. Spiral CT gives a three-dimensional view of the aneurysm and any attendant atherosclerosis. Ultrasound is useful for aneurysm screening and to monitor aneurysm size. Angiography gives helpful information by using contrast imaging to map the entire aortic system. Arteriography allows visualization of aneurysm and vessels. The main goal of care is to prevent the rupture of an aneurysm. Early detection and prompt treatment are essential. Conservative medical therapy of small asymptomatic aneurysm is the best practice. This consists of risk factor modification like ceasing tobacco use, decreasing BP, optimizing lipid profile, gradually increasing physical activity. Patients should receive management for hypertension, hyperlipidemia, diabetes, and other cardiovascular risk factors. Surgical repair is recommended in patients with asymptomatic aneurysms 5.5 cm in diameter or large. Surgical intervention is done sooner if the patient has a genetic disorder like Marfan, Ehlers-Danlos syndrome. Because in this condition, the aneurysm expands rapidly, the patient becomes symptomatic or the risk for rupture is high. Now we will see thoracic aortic aneurysm. Approximately 70% of all cases of thoracic aortic aneurysm are caused by atherosclerosis. The thoracic area is the most common site for dissecting aneurysm. Thoracic aortic emergencies are associated with high morbidity and mortality rate, but with the emergence of endovascular aortic repair, there is an improvement in the mortality rate. Clinical manifestations of thoracic aortic aneurysm. Thoracic aortic aneurysm are often asymptomatic. When present, symptoms include deep, diffuse chest pain that may extend to the interscapular area. Ascending aorta and aortic arc aneurysms can cause angina from decreased blood flow to the coronary arteries. And also it can cause transient ischemic attacks from decreased blood flow to the carotid arteries. Patient may have coughing, shortness of breath, hoarseness, or difficulty swallowing from pressure on laryngeal nerve. If the aneurysm presses on the superior vena cava, decreased venous return can result in jugular venous distension and edema of the face and arms. Symptoms vary and depend on how rapidly the aneurysms dilate and how the pulsating mass affects surrounding intrathoracic stretches. Some patients are asymptomatic. But in most cases, pain is the most prominent symptom. The pain is usually constant and boring. It may occur only when the person is in supine position. Dyspnea occurs as a result of a pressure of the aneurysm sac against the trachea or the lung itself. Cough may be frequently paroxysmal and with a brassicurity. Hoarseness, stridor, or weakness or complete loss of the voice occurs as a result of pressure against the laryngeal nerve. Dysphagia or difficulty in swallowing occur due to impingement on the esophagus by the aneurysm. And the symptoms of aneurysm of the thoraco-abdominal aorta, that is from the aortic arc to the level of the diaphragm. At first, there won't be any symptoms. Later, symptoms may come from heart failure or pulsating tumor mass in the chest. Pulse and BP difference in upper extremities if aneurysm interferes with the circulation in left subclavian artery. Pain and pressure symptoms like constant boring pain because of a pressure, intermittent and neuralgic pain because of impingement on nerves. Dyspnea causing pressure against trachea, cough often paroxysmal and brassing in sound, hoarseness, voice weakness or complete aphonia, that is a complete loss of voice, resulting from pressure against recurrent laryngeal nerve, dysphagia due to impingement on esophagus, edema of chest wall that is infrequent, dilated superficial veins on chest, cyanosis because of a vein compression of chest vessels, ipsilateral dilation of pupils due to pressure against the cervical sympathetic chain. Abnormal pulsation apparent on chest wall due to erosion of aneurysm through rib cage. Medical management of thoracic aortic aneurysm. Treatment is based on whether the aneurysm is symptomatic, is expanding in size, is caused by an iatrogenic injury, contains a dissection, and involves branch vessels. General measures such as controlling blood pressure and correcting risk factors are helpful. For decades, beta blockers like atenolol, metoprolol, carvedilol have been the mainstay of medical treatment for aortic aneurysms. However, angiotensin receptor blockers, for example, losartan, valsartan, irbesartan, may also retard aortic dilatation. It is also important to control blood pressure in patients with dissecting aneurysms. Preoperatively, the systolic pressure is maintained at approximately 90 to 120 mmHg in order to maintain a mean arterial pressure at 65 to 75 mmHg with a beta blocker such as esmolol or metoprolol. Occasionally, antihypertensive agents such as hydralazine are used for this purpose, and also sodium nitroprusside is used. It is given by continuous IV drip to emergently lower the blood pressure as it has a rapid onset and short action of duration and is easily titrated. That means we can adjust the dose of a medication for maximum benefit without adverse effects. Now we will see surgical management of thoracic aortic aneurysm. Thoracic aortic aneurysm are the most difficult to treat and require use of atrial circulatory bypass intraoperatively. The goal of surgery is to repair the aneurysm and restore vascular continuity with a vascular graft. Intensive monitoring is usually required after this type of surgery and the patient is cared for in the critical care unit. Repair of thoracic aneurysm using endovascular grafts placed percutaneously in an interventional suite. For example, interventional radiology, cardiac catheterization laboratory or combined interventional suite and operating room may decrease post-operative recovery time and decrease complications compared with traditional surgical techniques. Thoracic endografts are made of Gore-Tex or PTFE as the graft material and reinforced with the self-expanding litinol or titanium stents for structural support. These endovascular grafts are inserted into the thoracic aorta via various vascular access routes, usually the brachial or femoral artery. Because a large surgical incision is not necessary to gain vascular access, the overall patient recovery time tends to be shorter than with open surgical repair. Despite the absence of aortic cross-clamping, there is still 2% to 15% chances of spinal cord ischemia as a potential complication. To decrease the chance of spinal cord ischemia and paraplegia, lumbar spinal drains are usually placed in patients undergoing an endovascular repair of thoracic aortic aneurysms. Cerebrospinal fluid drainage is performed to decrease the arterial to cerebral spinal fluid gradient, thereby improving spinal perfusion. What appears to be most important in preventing neurologic deficit is to maintain the cerebrospinal fluid pressure less than or equal to 10 mmHg and to keep the mean arterial pressure greater than 90 mmHg for the first 36 to 48 hours post-operatively. Now we will see abdominal aortic aneurysm. The most common cause of abdominal aortic aneurysm is also atherosclerosis. Most of these aneurysms occur below the renal arteries, that is called infrarenal aneurysms. If it is untreated, the eventual outcome may be rupture and death. Abdominal aortic aneurysms can form in any of the following locations. Below the kidneys, it is called infrarenal. At the same level as the kidneys, it is called gestarenal. Above the kidneys, it is called suprarenal. The cause of abdominal aortic aneurysm, which is the most common type of degenerative aneurysm, has been attributed to atherosclerotic changes in the aorta. Now we will see the clinical manifestations of abdominal aortic aneurysm. Abdominal aortic aneurysms are often asymptomatic. They are often found during routine physical assessment or evaluation for another problem. A pulsatil mass in the periumbilical area slightly to the left of the midline may be present. Bruits may be auscultated over the aneurysm. Physical findings may be hard to detect in obese persons. Abdominal aortic aneurysm symptoms may mimic pain associated with abdominal or back disorders. Compression of nearby anatomic structures and nerves may cause symptoms such as back pain, epigastric discomfort, altered bowel elimination, and intermittent claudication. Sometimes aneurysms spontaneously embolize prey, causing blue toe syndrome, that is patchy mottling of the feet and toes in the presence of palpable pedal pulses. Only about 40% of patients with abdominal aortic aneurysms have symptoms. Some patients complain that they can feel their heart beating in their abdomen when lying down, or they may say that they feel an abdominal mass or abdominal throbbing. If the abdominal aortic aneurysm is associated with thrombus, a major blood vessel may be occluded, or smaller distal occlusions may result from emboli. Small cholesterol, platelet, or fibrin emboli may lodge in the interosseous or digital arteries, causing cyanosis and mottling of the toes. Signs of impending rupture include severe back or abdominal pain, which may be persistent or intermittent. Abdominal pain is often localized in the middle or lower abdomen to the left of the midline. Low back pain may be present because of a pressure of the aneurysm on the lumbar nerves. Indications of rupturing abdominal aortic aneurysm include constant instant back pain, falling blood pressure, and decreasing hematocrit. A rupture into the peritoneal cavity is rapidly fatal. A retroperitoneal rupture of an aneurysm may result in hematomas in the scrotum, perineum, flank, or penis. Signs of heart failure or a loud bruit may suggest a rupture into the vena cava. If the aneurysm adheres to the adjacent vena cava may become damaged when rupture or leak of the aneurysm occurs. A rupture into the vena cava results in higher pressure arterial blood entering the lower pressure venous system and causing turbulence, which is heard as a bruit. The high blood pressure and increased blood volume returning to the right side of the heart from the vena cava may cause right-sided heart failure. The most important diagnostic indication of an abdominal aortic aneurysm is a pulsatile mass in the middle and upper abdomen. Most clinically significant aortic aneurysms are palpable during routine physical examination. However, the sensitivity depends upon the size of the aneurysm, abdominal girth of the patient, that is more difficult to find in the patient with obesity. A systolic bruit may be heard over the mass. Now we will see the medical management of abdominal aortic aneurysm. If the aneurysm is stable in size based on serial duplex ultrasound scan, the blood pressure is closely monitored over time because there is an association between increased blood pressure and the aneurysm rupture. Antihypertensive agents including diuretics, beta blockers, ACE inhibitors, angiotensin receptor blockers, and calcium channel blockers are frequently prescribed to maintain the patient's blood pressure within acceptable limits. Now we will see the surgical management of abdominal aortic aneurysm. An expanding or enlarging abdominal aortic aneurysm is likely to rupture when an abdominal aortic aneurysm measured at least 5.5 cm wide or was enlarging. The standard treatment had been open surgical repair of the aneurysm by resecting the vessel and sewing a bypass graft in place. However, endovascular aortic repair has become a mainstay of therapy for treating an infrarenal abdominal aortic aneurysm and involves a transluminal placement and attachment of a sutureless aortic graft processes across an aneurysm. This procedure can be performed under local or regional anesthesia. Endovascular grafting of abdominal aortic aneurysm may be performed if the patient's abdominal aorta and iliac arteries are not extremely tortuous, small, calcified, or filled with thrombi. Eligibility criteria include iliofemoral vessels that allow for safe graft insertion and vessels of sufficient length and width to support the graft. The main section of the graft is bifurcated. It is delivered through a femoral artery catheter. The second part of the graft is inserted through the opposite femoral artery. When all graft components are in place, they are deployed against the vessel wall by balloon inflation. Blood then flows through the endovascular graft, preventing further expansion of the aneurysm. Angiography is done afterward to check for leaks and to confirm patency of all stent graft components. Because the blood is diverted through the endograft, aneurysm wall shrinks over time. Potential complications include bleeding, hematoma or wound infection at the arterial insertion site, distal ischemia or embolization, dissection or perforation of the aorta, graft thrombosis or infection, break of the attachment system, graft migration, proximal or distal graft leaks, delayed rupture, and bowel ischemia.